Afternoon, everyone. Thank you for joining us today with Dr. Nick Johnson. We will have the pleasure of hearing a great presentation on myotonic dystrophy, core features, clinical subtypes, and outcome assessments. And I'm happy to introduce Dr. Nick Johnson. Dr. Johnson, go ahead.
All right. Thanks for having me on. It's exciting to spend about an hour or so talking about myotonic dystrophy. So these are our learning objectives. So to identify the challenges in the diagnosis and management of myotonic dystrophy, describe the role of natural history studies and pathology in defining outcome measures, and then, of course, to guide patients to resources in myotonic dystrophy to support their ongoing care, including opportunities to participate in clinical studies. All right, so moving into myotonic dystrophy core features. So, this is really the hallmark of the disease. It's an autosomal dominant condition, which means that in each generation, each family members have a 50-50 chance of inheriting the repeat expansion. The core features are really defined by this weakness and wasting that preferentially affects distal, cranial, and respiratory muscles. And then myotonia, which is really best seen.
Squeeze, 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 and open.
And you can see here, this person's trying to open their hand as quickly as possible and just lots of difficulty relaxing. And while it's easiest, obviously, in a clinical exam to show that in the hand, that myotonia really is all throughout the body. So it's people talk about difficulty talking or communicating. The jaw can get stuck. The tongue can get stuck. It can affect individuals swallowing. It can affect gait, and it can certainly cause pain in the back, for example. So even though it's these kind of core features, it's a truly multi-systemic condition. Respiratory failure is the most common cause of death. Typically, this is a restrictive lung failure. And cardiac disease is the second most common cause of death. And so really bradycardia, heart block, and then obviously sudden death. Cataracts often develop before the age of 50. For the GI systems, the smooth muscle may be affected. So really, it looks like an irritable bowel syndrome with alternating diarrhea, constipation, and abdominal pain. And then in the endocrine system, there can be insulin resistance and thyroid dysfunction. And the brain, which is really, it's potentially one of the more debilitating areas of symptoms. Sleep regulation can be a problem. These patients are often night owls. They may have difficulty with central and obstructive sleep apnea. Narcolepsy might even occur. So really, profound daytime sleepiness and sleep regulations. But then, there's a full range of changes that may occur in terms of, an avoidant personality and potentially, mild dysexecutive function all the way to frank intellectual impairment. And one of the new kind of our more emerging features is that there's an overall increased risk of cancer in these patients. There's been probably 3 or 4 different studies at this point using population databases that have generally identified that individuals have a higher risk of a variety of different cancers. So that's the clinical perspective. What do patients talk about? So there have been two studies. There's more than 2 studies, but 2 studies I like. One is the CRISPR project, which is well over 1,000 patients that were surveyed. And the second is another survey that was done out of the University of Rochester, called the PRISM-1 study by Chet Heatwall. And so pretty consistent between these 2 different studies. So you can see in terms of symptom prevalence and impacts, muscle weakness, fatigue, daytime sleepiness, and balance issues, and myotonia, kind of top 5 issues. In the PRISM-1 study, fatigue, mobility, inability to do activities, problems with hands and arms, and daytime sleepiness. So, this kind of combination of problems with mobility, hand function, myotonia, as well as daytime sleepiness and fatigue is really the hallmark of kind of the symptomatic impact of myotonic dystrophy. But, it's worth noting if you look through the CRISPR project graph there that, there's lots of symptoms, well over 20 symptoms that get close to that 50% They're including things like abdominal pain, diarrhea, and anxiety. So it just, really is a multi-systemic condition. We did a study a few years back because one of the tricky things is if in myotonic dystrophy, anything can happen. Well, what is the relative risk? And so this is a study that used the Utah population database and compared the relative ICD codes from individuals living with myotonic dystrophies type 1 and 2 compared to those in the population control, so age and sex matched population control. And so, consistent with what I've said already, so cardiac conduction disorders, well over 60 times the relative risk compared to the general population, a higher increased risk of obstructive and central sleep apnea, a higher risk, about 6 times risk of any cataract. And in this particular study, the cancers that were identified as an increased risk included testicular and chronic lymphocytic leukemia. So, kind of it's another way of commenting on the overall multisystemic and multiple comorbidities that patients can have. So, how does DM1 occur? Well, so myotonic dystrophy type 1 is one of many repeat expansion disorders. And here, the repeat expansion is in the 3' untranslated region of the DMPK gene on chromosome 19. And it's a little bit of a unique disorder in the sense that it's really a toxic RNA gain of function. So what happens at the RNA level is that as the DMPK transcript is transcribed, it forms these hairpin loops and sequesters important splicing proteins such as muscleblind, and that causes generally dysregulated RNA splicing. You can see this in cells. Here are nuclei. In the left column, you can see the unaffected nuclei. In the right, you can see the DM1. And in panels B and F, you can see the foci accumulate from the nucleus in the myotonic dystrophy type 1. And then in G, you can see the CUG repeats. And then you can see that these co-localize together. And these foci is one of the kind of molecular hallmarks of the condition. So, all right, so it sequesters the muscleblind protein. Well, what's the big deal? So muscleblind, along with other proteins, including RB-FOX and others, are involved with RNA splicing. And so here, what you can see is that if you have the appropriate muscleblind, that you it's in charge of either including or excluding the appropriate exon. But in myotonic dystrophy type 1, it's segregated in those repeats. And so rather than including the exon that you're supposed to include, you exclude it, making it fetal isoform. And that's really what causes the symptomatic impact. So you can see, for example, the chloride channel is misspliced, and that's what causes myotonia. The insulin receptor is misspliced. That may in part lead to the insulin resistance. Several other genes that are important in cardiac conduction, including TNT2, and SCN5A, are involved with cardiac conduction and may lead to arrhythmias. And so, this really happens. Well over 2,000 different transcripts are misspliced and across multiple different organ systems. And this combination of events is what leads to the disease symptoms and symptomatology. What's interesting about this is if you really think about it in terms of a therapeutic modality, is that you're not making a toxic protein. And the main issue is that the muscleblind sequestered. So in theory, if you're able to release the muscleblind either by removing those CUG repeats or upregulating muscleblind protein or otherwise blocking the interaction between muscleblind and those repeats, any of those strategies may allow muscleblind to function normally and allow RNA splicing to proceed as you would expect it to. So, and then in fact, many of those approaches which I just mentioned are moving through clinical trials now. All right, so let's talk about the diagnosis and management. So myotonic dystrophy is actually a very common rare disease. We did a study a few years back when I was at the University of Utah, where we took 50,000 newborn blood spots and we screened them for the repeat expansion. We used what's called the triplet prime PCR because you get just a little bit of DNA. That's not enough to do a southern blot. And then we confirm that using this Asuragen AmplideX PCR. And this is a schematic kind of showing what we did. So what did we find? So when out of the 51,000 repeats, there were 143 positive. There were 610 pre-mutations, and there were actually over 7,000 high normals. So these are kind of the population at risk of repeat expansion in future generations. And that actually leads to a combined prevalence of 1 in 2,100, which is just barely rare. One thing to note in this study is that while we were unable to confirm the repeat length of the longer repeats, those that were over 200, about half the individuals who screened positive had repeats between 50 and 150, which tells you that these are people who are mildly affected, probably don't even know they have disease, but certainly at risk of the cardiac arrhythmias that come, the cataracts that develop, and of course passing on a more severe form in the future. So really, this is a shockingly high prevalence, and certainly I expect a higher prevalence than what you were expecting to see or what you see in your clinic, and that really reflects that difficulty in diagnostic odyssey. So we know from work that out of the Rochester Registry for DM1 patients and family members that patients on average wait about 7 years for diagnosis. And that really is most reflected in people who don't have a strong family history. And in fact, at least in my clinic, and I'm sure in many of yours, if you really think about it, a lot of times families come to recognition because they have a patient that was born with the most severe form, the congenital onset, which is quite serious at birth and certainly drives diagnostic investigation. And so, we as a community have to find a way to do a better job of finding these patients, bringing them into clinic, and I think that's particularly relevant because of these emerging clinical trials that are ongoing. So there are currently, however, no approved therapies for myotonic dystrophy type 1 or type 2. And right now, the current treatment is focused on symptomatic care of daytime sleepiness and myotonia, often using medicines like modafinil for daytime sleepiness and mixilotine for myotonia. And really, care should be given in a multidisciplinary involvement with annual ECGs, pulmonary function tests, and other screening tests for endocrine abnormalities. And for those who are interested in this JAMA Insights, there's actually a really nice table which gives you kind of the lay of the land and what to do with the patient in front of you in clinic on an annual basis. Myotonic dystrophy as a whole is a life-limiting disorder, so the mean age of death is 55, typically due to either cardiac or pulmonary causes, as I mentioned before, although neoplasms rank third in terms of the overall cause of mortality. I kind of mentioned this, but I'll take you through this. So, there are multiple different therapeutic strategies here. So you can either inhibit transcription, which you can see there using ASOs. You can degrade the CUG expansion, usually using, again, ASOs or RNAi. You can inhibit the interaction between muscleblind and the CUG repeats, again, using ASOs or small molecules or peptides. And in fact, at every step there, particularly middle two steps, there are active clinical trials that are working with precision therapies that are currently working their way through phase 1 through 3. It's not to be underemphasized that it's also important to think about correction of symptoms like daytime sleepiness, the myotonia, and other approaches that can be developed. But with all that therapy development, we do certainly need biomarkers to assess changes in DM1 specific outcomes. So let's define those biomarkers and outcome measures. So the Myotonic Dystrophy Clinical Research Network was originally formed in 2013 to develop clinical outcomes for myotonic dystrophy type 1. It has been generally supported by the Muscular Dystrophy Association throughout that time. And our goal was really to understand which outcomes are sensitive to change, prepare sites and patients for clinical trials. So this is a map looking at the current 22 sites. It's really a multinational organization. It's coordinated here at Virginia Commonwealth University, along with the University of Rochester. And we do have several ongoing studies, which I'll show some data from. The largest is NDM1, which is a natural history study seeking to enroll 700 individuals and characterize their disease progression over a period of 24 months. I'm happy to say that we're well over 600 patients enrolled at this point and should be ending enrollment hopefully by the end of this fall. And then we also seek to develop a muscle RNA alternative splicing event as a biomarker of severity. And this is a schematic showing the NDM1 study overview. So, pretty simple and certainly supported by multiple different industry partners, as well as the FDA, the Myotonic Dystrophy Foundation, and the MDA. What are some things that we think about in terms of these outcome measures? So I'm sorry that the circle got off a little bit there, but this is a highly heterogeneous condition, and projected here is a 12-month change in a 10-meter walk run, and so you can see here that the lower the number, the faster you are, and actually. If you look right about 5 seconds, you can actually see that individuals who are below 5 seconds tend to be pretty fast and stay pretty fast. But if you start to look at those individuals above 5 seconds, you can actually see that they certainly develop at a more rapid pace. And that's a suggestion that, potentially we could use something like the 10-meter walk run to guide us in terms of, which patients are best suited for clinical trials. Obviously, if somebody's running at 4 seconds, it's hard to do much better over that time period. And so, you're looking for patients who have room to improve. This data has been based off of, two prior studies, so STOP DM1 and DM which both used a 30-foot walk run, roughly equivalent to a 10-meter walk run. And there you can see that the change about 6%. When this was evaluated in DM1, right at that point, the percent change was actually about 11%, but we'll have to see how that finishes up because that study is still ongoing. Another way of looking at it is the forced vital capacity, same idea here. And so actually, again, you can see that for those individuals who have a forced vital capacity over 80%, pretty minimal decline, but as you might expect, for those individuals who have a forced vital capacity under 80%, you begin to see more rapid change. And you can actually see, fairly similar to the prior DM and STOP DM change, about a 5% change in the overall population in terms of the annual rate of change on that forced vital capacity. So I think, those two, it's actually remarkably consistent across a number of different outcome measures. So 10-meter walk run, hand grip strength, forced vital capacity at a population level. The overall rate of change of an individual is about 5% per year. And so that's a number, patients are asking you about what the rate of decline is. That tends to be, the overall average. Underneath that average, that curve is probably not strictly linear, and that there are time periods where people may hit a threshold effect or a tipping point, and that rate of change may actually be a little bit more than that overall 5%. So let's talk a little bit about myotonia. It's in the name of the disease. It is a complicated symptom to evaluate because it doesn't follow a strictly linear path of disability. So when you think about myotonic dystrophy as it relates to DM1, it's a combination that we know the chloride channel causes a missplicing, can cause myotonia. We also know that the calcium channel can be misspliced, and work by John Luke at the University of Rochester has shows that actually can aggravate the myotonia. And that combination can actually lead to both both the myotonia, but also the progressive inexcitability and weakness. And we don't really know, but the hands do appear to be particularly involved. And so at the bottom left corner, you can see this conceptual model for how we think about hand progression, so that at the beginning of the disease, the myotonia gets worse, but as the weakness develops and progresses, actually the myotonia tends to improve, probably because there's not enough muscle there to mount a myotonia response, and so that leads to this kind of hypoexcitable muscle. And that conceptual model, at the end of the day, really just leads to progressive disability. It's hard for patients in clinic to say, well, is that my myotonia or is that my hand weakness? People really just talk about, difficulty opening jars or bottles, or difficulty opening doors, or doing buttons. It's hard to parse out clinically, whether or not it's a myotonia or the weakness specifically. However, again, when you go back to thinking about the therapeutic development, in the bottom right corner, work done by Charles Thornton's group at the University of Rochester, you can see, that when you provide an antisense knockdown affecting the RNA splicing, which is what's shown there, you can actually see that the RNA splicing improves pretty quickly, and that the myotonia follows suit. So this is kind of a summary thinking about these key clinical outcome assessments. So the 30-foot walk run or the 10-meter walk run, either one is fine to use. They're fairly interchangeable. Again, showing about a 6% change, highly reliable in this group, and timed up and go. Again, about a 6% change, highly reliable. Grip strength, supine force vital capacity, again, highly related outcome measures. And roughly speaking, about a 5% change over the course of a year. So, when you think about the clinical trials that are ongoing, these are some of the functional measures that one might consider. And in fact, data that has been presented previously by Avidity showing the results of their Marina open label extension study, comparing to the NDM1 study. So you can see a video hand opening time, hand strength in the middle, and then DM1 active, which is a patient-reported outcome. You can actually see in all instances in the NDM1 study, either these were stable over the course of 12 months or they were slightly declining, but that when patients were provided the highest dose of an siRNA conjugated to a transferrin 1 receptor, that in fact that they had general improvement, suggesting that this is really a modifiable disease, and that these new therapies have a lot of promise to them. All right, so let's move beyond clinical outcome assessments and start to talk about RNA splicing as a biomarker. So this is a kind of complicated slide, but really it's an illustration of that RNA splicing follows along with a dose response curve. So you can see that best in panel A, looking at something like class 1, where you can see that the relative splicing, which is shown on the y-axis, gets better with increasing levels of muscle-blind, free muscle-blind, and not sequestered by the repeats. And so this gives you a feel that, again, RNA splicing is not linear, but really follows a parabolic curve, and that potentially you could use some of these RNA splicing values to measure the change or the amount of muscle blind that's sequestered by the repeats. The trick would be, for example, if you use one event, it might be, a little bit more or less sensitive to muscle blind, and so in that instance, you're subject to much more variation. And so this paper suggested, for example, that if you use 10 potential events, you might smooth out some of that variation between individual events and might serve as a better biomarker. And this has been supported in the past by work, again, out of the University of Rochester, using not the newer RNA sequencing, but this is using RT-PCR and showing that, for example, there's a pretty good correlation between the degree of strength and the amount of RNA missplicing that's seen. But as I alluded to, some different splicing events like BIN1 are a little bit more sensitive or variable associated with the degree of strength and missplicing. Other events like insulin receptor, for example, are not particularly sensitive. So you can see that they're normally spliced here, but that really they're quickly misspliced even in individuals with full strength. This work has been posted now in bioarchives. It's really been led by Melissa Hale here at VCU, and is looking at 46 participants with myotonic dystrophy, and you can see there that pretty moderate strength impairments in terms of hand grip, ankle dorsiflexion. They're a pretty moderately affected in terms of their 10-meter walk run, and they have a pretty wide amount of myotonia. So here we used 22 different splicing events called the target RNA splice index and compared and said, well, is this representative of the overall amount of missplicing and total RNA-seq? And you can actually see that there's a very strong correlation between the overall amount of missplicing that's seen as well as this smaller 22 event panel. Okay, well, how does this 22 event do when comparing to motor function? And so you can see there's actually a pretty strong correlation looking at either ankle dorsiflexion, hand grip strength, or the 10-meter walk run, where the splice index here is more impaired, and then here it's better off, and you can actually see again that it does a nice job of correlating with physical function. So just a little bit duplicate, yeah. So out of the 22 different events, I get asked this question often: what are the most important? Well, they are highly correlated with each other, and so actually they perform really well. And one way of looking at that is, for example, pick the top 5 that correlate with a particular functional measure. So like hand grip strength here, and you can see that these top 5 events out of the 22 correlate with hand grip strength about 0.71, but the entire 22 events still correlate at 0.7. So really, these events are really tightly interlinked. If you were paying attention a few slides ago and you saw that the insulin receptor was not particularly sensitive, it's not surprising to you that this is really at the bottom of the correlation events across multiple different outcome measures. Yeah. And again, kind of here emphasizing that the chloride channel and here and then the calcium channel do tend to drive the overall degree of missplicing in these patients, which is fairly consistent with work that has been done more recently in mouse models. So it's really suggests that to some extent the weakness is potentially really driven by the ion channelopathy. So how does this do over time? So here, this is looking at the baseline slice index versus baseline strength, and here's the 3-month versus the 3-month strength, and so you can see that those correlations hold when comparing the baseline to baseline and 3-month to 3-month. and that the overall reproducibility of the spice index, which is shown here, look at the baseline to the 3-month score is about 0.86, which is pretty good. But I'll draw your attention to that this middle group here, those with kind of moderate splicing impairment actually seem to have a little bit more variation than those that either with pretty mild splicing impairment or pretty significant splicing impairment. And this is just another way of kind of demonstrating what I was just talking about that. So you can actually see that if you look at those individuals again in that kind of middle group here, you can actually see that they have much more variability. That's probably biological variability compared to the those with mild or more severe splicing changes. And this graphically shows that. So if you, again, subdivide them, so this baseline, so these are individuals with mild splicing impairment. There is a little bit of trend towards worsening of the splicing impairment, but again, you can see that the 10-meter walk run was really not changed at all. Here in that moderate group, you can actually see a more significant change, which is not quite reflected in terms of the overall rate of ambulation. And then in the more severe, again, you can see, that there's really no change. So this suggests that if you get into that kind of middle part of that parabolic curve, the splicing dysregulation is probably much more dynamic than I think we had previously predicted. It's just, again, looking at the fact that there's really no change in terms of strength or function. And so, could the splicing index predict what the future physical function? So again, just to remind you that this is the baseline spice index versus the baseline strength or speed in terms of ankle dorsiflexion or 10-meter walk run. But you can actually see if the animation, let's see if I can stop that. There we go. That the correlation actually improves by about 0.1 if you look at the baseline compared to the 3-month in both outcome measures. So again, the baseline splice index correlates better with 3-month measures, which suggests that it's not surprising. When you're measuring RNA splicing, you're looking at something that is not made into a protein yet. It's not functional yet, and so it suggests that the RNA splicing changes could occur or may be predictive of a phenotypic response. And in fact, if you look at the combination of the baseline spice index and ankle dorsiflexion strength, it's about the adjusted R square is about 0.83, which suggests that these combinations are really highly predictive of future function. It's interesting to think that this might serve as a prognostic biomarker. I'm going to switch gears completely for the second half here and talk about congenital myotonic dystrophy and the overlapping features that you might see with myotonic dystrophy type 1. So as a reminder, in myotonic dystrophy, there's anticipation. So the CTG repeat expansion may actually increase between generations. And typically that increase is most significant or profound when being passed from mothers to children, then from fathers to children. And so you can see, this can result in a varying symptom onset. So when symptoms develop at birth, that's known as congenital myotonic dystrophy type 1. When symptoms develop between ages 1 and 10, that's childhood myotonic dystrophy. And over age 10, it's really classified as adult onset myotonic dystrophy. And this pedigree of a family that I previously took care of really underlines this point quite significantly. So here's the proband who was diagnosed with congenital myotonic dystrophy at birth with 1,100 repeats. You can see a sibling here, still with a pretty significant increase and had childhood onset myotonic dystrophy type 1, as did a cousin. But both mothers here really only had about 150 or 97 repeats and were not particularly symptomatic. And of course, the grandfather, same thing, not particularly symptomatic. So really fairly stable going from the father to the 2 daughters, but then in both instances, you had that more significant repeat expansion. So congenital myotonic dystrophy typically occurs really in the first day of life. But sometimes when you're seeing patients in clinic, it's hard for them to say, quite remember. And so, a little bit more generous sometimes and say, well, it has to have symptoms within the first month of life. And that really has profound facial weakness, intellectual impairment, autism spectrum and ADHD and irritable bowel syndrome. And importantly, the kind of characteristic weakness and myotonia often develop later in the disease. So with my very first Myotonic Dystrophy Foundation fellowship grant, we did a survey of 150 parents and asked them to rate the relative impact of the various different symptoms by the age of their child. So this is a parent proxy reported score, and you're not really supposed to pay attention to the multitude of different symptoms, but I hope that what this shows is this kind of triphasic pattern, which you can see here, where you really have in the infant period significant respiratory failure, feeding difficulties, clubfoot, and hypotonia. And then interestingly, really those symptoms almost universally improve. And in childhood, it's marked by this intellectual impairment, autistic features, ADHD, and GI issues like the irritable bowel or even fecal incontinence. And then in adolescence, typically kind of the harbinger of the adult symptoms include myotonia, fatigue, and the distal weakness, which at that point become progressive and more consistent with the kind of fairly steady progression that we see in adults with disease. So we've previously done a series of different studies looking at the natural history of children in congenital myotonic dystrophy, and we used this particular inclusion-exclusion criteria in these kids. So they had to be hospitalized for 72 hours in the first month of life, and then they had to either require breathing assistance or feeding assistance or clubfoot or have hypertonia, which is really the kind of research definition of congenital myotonic dystrophy, and they had to have at least a repeat length of over 200, which is still a pretty low bar. And so you can actually see from this initial study that the mean duration of respiratory support at birth was about 26 weeks, but highly variable, anywhere from 1 week to 156 weeks. And that currently in the group when it was measured, about 24% of those patients were still using BiPAP, and 12% were using supplemental oxygen at night, and then one was still ventilated. One thing we weren't quite expecting is you could see in the kids actually they had already developed some of the cardiac manifestations. I think previously it was thought that these cardiac arrhythmias tended to occur later in the disease, but in fact it's important to screen as early as possible for the cardiac arrhythmias that develop in myotonic dystrophy. So this is work that was done by Kellen Quick, who was a medical student at the time, went on to do a neurology residency. And this is looking at a vector plot of the kids, looking at their pinch or their grip strength. And I'll focus on the grip strength because what you can see is each individual child followed along. But in the background, you can see data that was contributed by Josh Burns and the 1,000 Norms Project, where you have normal development scores of healthy children. And so you can see, you don't particularly see the decline that you might expect to see, say, for example, in Duchenne muscular dystrophy. What you tend to see is a fairly stable amount of weakness, particularly in terms of the grip strength here, and then look somewhat normal, but in fact really start to begin to separate from their healthy controls over time, except for a few outliers. And here, this is looking at the 10-meter walk run, and then 6-minute walk, again over 12 months. And again, I would focus you in to show that basically, as I was noting, kids in this kind of childhood age continue to gain function. They continue to gain strength. They continue to gain speed and ambulation, and can gain function. However, you can see that they never quite reach the healthy controls, and in fact, as they plateau in adolescence, that separation starts to accentuate from what you see during the course of normal development. What about cognition? So this is looking at a series of different cognitive measures, and you can see, looking at the full scale IQ of 65, which is really quite low, although there's a huge range, and 103 would be considered average IQ. Looking at the range of the Vinland in terms of the adaptive function, again, poor adaptive function. The brief here measures executive function, and you can see again low scoring executive function. And then the ASSQ is a measure of autism, and this score of 16 puts them just above the cutoff as for qualifying for a diagnosis of autism. And this summary here begins to look at that mean change. Again, these numbers are small because it's a rare disorder, but you can see, gaining function, for example, of about 50% in those who are under 10 years of age, and that gain tends to slow down over 10 years of age. And then if you come down here to look at the pediatric daytime sleepiness, you can see, there's a little bit of improvement, but here you can start to see the first signal of the adult features in that those over the age of 10 tend to report increasing daytime sleepiness. So how about, let's go back to that alternate splicing and composite splicing index. How does it look? Do these look the same as adults with DM1? In fact, they're much more heterogeneous. So just to kind of orient you, there are 4 groups in this study. So there's 36 children who had biopsies with congenital myotonic dystrophy between essentially 2 weeks and 16 years of age. Here, there were 22 adult DM1 patients that were included, 21 pediatric controls contributed by the University of Iowa's Wellstone Center, core resource, and then 7 adult controls. And if you start to look, for example, at the chloride channel event, you can actually see a much wider spread of RNA splicing dysregulation in the children with congenital myotonic dystrophy compared to the adults with DM1. That's reflected again here, and again, actually with that insulin receptor. And this is a heat map essentially showing how these groups correlate. Again, children with congenital myotonic dystrophy are highlighted in red and actually group in several different areas. So this group of congenital myotonic dystrophy patients grouped nicely with adults with DM1, but there's this other outlying population here. This is I think, easier or simpler way of actually looking at this, and probably a key take-home point from this particular talk, thinking about congenital myotonic dystrophy. So here we don't use a composite splicing index. We use a measure called the MBNL inferred, where 1 is normal splicing and 0 is a very bad splicing or missplicing. And each child here is represented by their age. And you can actually see 4 groups develop here. So consistent with their clinical presentation, those individuals under the age of 2, you can see with pretty significant missplicing. That's not surprising because these kids are really pretty severely affected. What is a little bit surprising is that in childhood here, you actually see fairly normal RNA splicing. In fact, many of these kids have completely normal RNA splicing in their vastus lateralis. And then after the age of 8, you start to see 2 groups develop here. These individuals revert or have the more significantly misspliced characteristics, and here these individuals maintain a pretty normal RNA splicing pattern. And we're actively working on both what drives this RNA splicing to improve, as well as what may trigger or cause individuals to have a progression of their missplicing. I'll call out 2 particular individuals. So this child here was biopsied at 2 weeks and again 8 years. So that's a single longitudinal biopsy, but proving the point that he naturally had about a 60% improvement in his RNA splicing, just over the course of his development. And this girl here was biopsied at 2 points over the course of 4 years, and again, here maintained a pretty normal splicing profile. So I think it's interesting, and certainly if you think about kind of that triphasic model of progression, this probably is being driven or seen from the RNA splicing level as well. One theory about what causes that triphasic pattern of progression, which again is an area of active research in our lab, is potentially, the overall expression of DMPK. So, in adults, we know that the CUG repeat or CTG repeat expand over time, and that as that repeat gets larger, it likely drives more MBNL sequestration, and that's potentially the kind of underlying cause of progression over time. However, one notable thing that you can see here, looking at the relative expression of DMPK, shown here in CDM infants, and again here in just a different graphical representation, you can actually see the DMPK expression is highest in those individuals earliest in life. And so it's a very small sample set, and certainly we need more data and longitudinal data to capture it, but it may suggest that potentially that initial kind of severe infant presentation may be driven by DMPK expression, which kind of adds a repeat load just by increasing the total number of transcripts. And then perhaps maybe, when you develop symptoms in adolescence, what you're seeing there is that somatic instability and the repeats themselves driving the progression, same as what we would expect to see in adults. We don't particularly like taking biopsies from children. And so, is there a way to do this differently? So this work being done by Julie Hartman, who's an MD PhD student in our lab. I'll draw your attention to, so this is essentially looking at the MBNL inferred. So this is the RNA splicing level compared to a number of different, here's ankle dorsiflexion, here's a 9-hole peg, here's a running speed, and 6-minute walk. And you can see the different groups here: infant, children, adolescent 1, adolescent 2, and then adults. And you can see that with the ankle dorsiflexion, the kids with congenital myotonic dystrophy have a hard time performing that. And so the correlation reduces as you take away those adult samples. However, for example, in the 9-hole peg, actually, the correlation improves, probably because these kids have a much more significant hand weakness. But you can see that the correlation remains present when looking at, for example, running speed on the 10-meter walk run, and actually improves when looking at that 6-minute walk test. So can you predict the underlying RNA splicing using a combination of clinical metrics? So here is looking at DM1 individuals as well as CDM only. And again, it's a small sample set, requires additional validation. But it suggests by using a combination of the percent change on the 9-hole peg test and walking speed, you might actually be able to do a pretty good job of predicting what the underlying missplicing characteristics are, which would be helpful and potentially remove the need to continue to take lots of muscle biopsies from kids. I think when you're thinking about myotonic dystrophy in kids, it is the most severe form of the disease. It does have this really interesting triphasic pattern of progression with this natural improvement in childhood. So this is a complicated trial to design, and I think we're still working on how you might design a trial to demonstrate efficacy of these exciting RNA therapeutics that are currently moving forward in adults. It's important to remember that these children do have significant CNS burden. And that that needs to be accounted for in terms of potentially here you might be looking for drugs that are more able to cross the blood-brain barrier. So in summary, myotonic dystrophy is a multisystemic disease. Preventable cardiac arrhythmias are the leading cause of mortality. Clinical features with congenital myotonic dystrophy are distinct from DM1, but it's also a multisystemic condition. Symptoms in congenital myotonic dystrophy do generally improve with age. The underlying pathogenesis of CDM is the same with DM1, as I hope I showed. And really, most excitingly, there are promising trials that are underway. So on behalf of our center, I'd like to particularly call out Dr. Hale, who did a lot of the work with the RNA splicing, our clinical operations team in finance operations, Aaron Spain and Kelly Doyle, and then, of course, the evaluators who collected all the data. And I'm going to turn you to a couple of different resources. So some key publications That article or review by Julie Hartman does a really nice job of summarizing kind of the key steps in terms of the care. If you want something longer and more detailed, at Myotonic Dystrophy Foundation, there's the consensus guidelines and their toolkits and publications. And so there's one for myotonic dystrophy type 1, for type 2, for cardiac management, for congenital myotonic dystrophy. So really, and then for anesthesia guidelines. So really, this should be, if you're talking to your local surgeon and looking for a clearance, this should be your go-to place. As I mentioned, the NDM1 study is looking for individuals ages 18 to 70 with a DM1 diagnosis by research criteria or genetic test, and your study contact is listed right there, or you can always email me.